Good morning, my friends. I'm Dr. Armen Astvatsatryan from Yerevan, Armenia, and today we continue to talk about acute myocardial infarction. Let's start with the second part of our lectures, so prognosis for acute myocardial infarction. So global risk should be estimated via formal clinical risk scores, or so-called STEMI, or a combination of the following high-risk features: recurrent angina, ischemia at rest or during low-level activity, heart failure, worsening mitral regurgitation, high-risk stress test result, so test stopped in less than 5 minutes due to symptoms, marked ECG abnormalities, hypertension, or complex ventricular arrhythmias, hemodynamic instability, sustained ventricular tachycardia, diabetes mellitus, PCI within past 6 months, prior coronary artery bypass grafting, cabbage, and left ventricle ejection fraction less than 40. This is about global risk that should be estimated via these high-risk features. Overall mortality rate prior to the modern area of treatment with fibrinolytics and PCI was about 30%. with 25 to 30% of these patients dying before reaching the hospital, typically due to ventricular fibrillation. Actually, we talk, this is not 25 to 30, about 50% of patients. In hospital, mortality rate is about 10%, typically due to cardiogenic shock, but varies significantly with severity of left ventricle failure. So this is about left ventricle failure or acute heart failure. This is a Killip classification. Now I will talk about just in a few minutes. For patients receiving reperfusion, fibrinolytics or PCI, in hospital mortality is 5 to 6% versus 15% for patients eligible for reperfusion who do not receive reperfusion therapy. In centers with established primary PCI programs, in hospital mortality is reported to less than 5%. Most patients who die of cardiogenic shock have an infarct or a combination of scar and two infarct affecting more than 50% of total left ventricle mass. 5 clinical characteristics predict 90% of the mortality in patients with STEMI. Older age. 5 clinical characteristics. Older age. So 31% of total mortality. Lower systolic blood pressure, 24%. Killip class more than 1, 15%. Faster heart rate, 20%, and anterior infarct location, 6%. Mortality rates tend to be higher in women and in patients with diabetes mellitus. Mortality rate of patients who survive initial hospitalization is 8 to 10% in the year after the acute myocardial infarction. Most fatalities occur in the first 3 to 4 months. Persistent ventricular arrhythmia, heart failure, poor ventricular function, and recurrent ischemia indicate high risk. Many authorities recommended stress ECG before hospital discharge or within 6 weeks. One of these authorities is me. Good exercise performance without ECG abnormalities is associated with a good, favorable prognosis. Further evaluation is usually not required. Poor exercise performance is associated with a poor prognosis, obviously. Cardiac performance after recovery depends largely on how much functioning myocardium survives the acute attack. Acute damage adds to scars from previous infarcts, so when more 50% of left ventricle mass is damaged, prolonged survival is unusual. But it happened. Okay, now Killip class of acute myocardial infarction. So when you will find question in your exams, in tickets of your exams, is in your exam tickets, acute heart failure. Don't look it for in chronic heart failure. This is acute heart failure. Acute heart failure is a Killip classification of acute myocardial infarction. So we've got 4 classes of this classification. Class 1, normal. Normal oxygen supply, or just normal. Class 1, normal, or just class 1. So no clinical evidence of left ventricle failure. So any infarction without evidence of acute cardiac failure, that Killip 1. No complication, very good, but Killip 1. There is no Killip 0, just Killip 1. Killip 2, slightly reduced. So slightly reduced is determined while the patient is breathing room air. So clinical descriptions: mild to moderate left ventricle failure. Mild to moderate left ventricle failure. Actually, Killip 1 is mild ventricular failure, but okay, let's talk that class 2 is moderate left ventricle failure. So I remind you that this classification exists from 1967. Killip and Kimball. We'll talk about Killip classification. Mild to moderate left ventricle failure. Then Killip 3. Killip 3 is abnormal. Abnormal, of course, severe left ventricle, pulmonary edema. So Killip 3 is severity of urgence. And Killip 4, severely abnormal. This is actually cardiogenic shock, hypertension, tachycardia, mental obduration, cool extremities, oliguria, and hypoxia. So actually in Killip 4 is a sign of death. No, death is coming. Okay. Now about treatment. Yes, let's talk about treatment. Treatment of myocardial infarction. So, of course, it's the same. Once again, it's the same as in acute coronary syndromes. Actually, this is the same history of all this chain, or this is continuum of metabolic syndrome, atherosclerotic disease, coronary artery disease, clinical manifestation as angina, stable angina, and acute coronary syndrome, and stable angina, myocardial infarction. The same. So pre-hospital care: oxygen, aspirin, nitrates, and triage to an appropriate medical center. Drug treatment: antiplatelet drugs, antianginal drugs, anticoagulants, and in some cases other drugs. So actually I intend to make one lecture just concerning drug therapy in acute myocardial infarction. Maybe the next lecture you've got once. Reperfusion therapy, fibrinolytics or angiography with percutaneous coronary intervention or coronary artery bypass surgery. Post-discharge rehabilitation and chronic medical management of coronary artery disease. Choice of drug therapy and choice of reperfusion strategy we will talk elsewhere. Okay? Pre-hospital. So reperfusion strategy, actually we talk about this in treatment of acute coronary stenosis. And drug therapy it will be in another lecture. Okay, let's do like this. So pre-hospital care. Pre-hospital care. Oxygen, aspirin, nitrates, triage to appropriate medical center. A reliable intravenous route must be established, oxygen given, typically 2-liter binasal cannula, and continuous single-lead ECG monitoring started. Pre-hospital interventions by emergency medical personnel, including ECG, chewed aspirin, 325 milligrams, but actually you can use any aspirin you want, and pain management, without coat of course, and pain management with nitrates can reduce risk of mortality and complications. Early diagnostic data and response treatment can help determine the need for and timing of revascularization. Now hospital admission. Risk stratify patient and choose reperfusion strategy. Drug therapy with an antiplatelet drugs, anticoagulants, and other drugs based on reperfusion strategy. On arrival to the emergency room, the patient's diagnosis is confirmed. Drug therapy and timing of revascularization depend on the clinical pictures and diagnosis. For STEMI, reperfusion strategy can include fibrinolytic therapy or immediate PCI. For patients with non-STEMI, angiography may be done within 24 to 48 hours of admission if the patient is clinically stable. If the patient is unstable, for example, ongoing symptoms, hypertension, sustained arrhythmias, then angiography must be done immediately. Okay. But drug treatment, right? Drug. But anyway, I intend to do this. On one lecture, just drug treatment. All patients should be given antiplatelet drugs, anticoagulants, and if chest pain is still present, anti-anginal drugs. The specific drugs used depend on the reperfusion strategy and other factors. Their selection and use will be discussed in drugs for acute myocardial infarction. Other drugs such as beta blockers, angiotensin converting enzyme inhibitors, AC inhibitors, and statins should be initiated during admission. Patients with acute myocardial infarction should be given the following unless contraindicated. Antiplatelet drugs, so aspirin, clopidogrel, or both. Prasugrel or ticagrelor are alternatives to clopidogrel. Anticoagulants, heparin, unfractioned or low molecular weight heparin or bivalirudin. Glycoprotein 2B3A inhibitors when PCI is done. Anti-anginal therapy, usually nitroglycerin, beta blocker, anti-AC inhibitor, and statin. All patients are given aspirin 160 to 325 milligram, non-enteric-coated, if not contraindicated at presentation, and 181 milligram once a day indefinitely thereafter. Chewing the first dose before swallowing quickens absorption. Aspirin reduces short-term and long-term mortality risk in patients undergoing PCI. A loading dose of clopidogrel 300 to 600 milligrams orally once, prasugrel 60 milligram orally once, and ticagrelor 180 milligram orally once improves outcomes, particularly when administered 24 hours in advance. For urgent PCI, prasugrel and ticagrelor are more rapid in onset and may be preferred. Enter a low molecular weight heparin. Unfractioned heparin or bivalirudin is given routinely to patients unless contraindicated, for example, by active bleeding. Unfractioned heparin is more complicated to use because it requires frequently, every 6 hours, dosing adjustment to achieve target-activated partial thromboplastin time, APTT. The low molecular weight heparin have better bioavailability, are given by a simple weight-based dose without monitoring APTT and dose titration that have lower risk of heparin-induced thrombocytopenia. Bivalirudin is recommended for patients with known or suspected history of heparin-induced thrombocytopenia. Anticoagulants are continued for duration of PCI in patients undergoing this procedure, duration of hospital stay in patients on low molecular weight heparin, or 48 hours in patients on unfractioned heparin or in all other cases. Consider the glycoprotein 2B3A inhibitor during PCI for high-risk lesions, high thrombus burden, no reflow. Apiximab, tirofiban, and eptifipadid appear to have equivalent efficacy, and the choice of drug should depend on other factors. For example, cost, availability, familiarity. This agent is continued for 6 to 24 hours. Chest pain can be treated with nitroglycerin or sometimes morphine. Nitroglycerin is preferable to morphine, which should be used judiciously. For example, if patient has some contraindications in nitroglycerin or is in pain despite nitroglycerin therapy. Nitroglycerin is initially given sublingually, followed by continuous intravenous drip if needed. Morphine 2 to 4 milligrams intravenously, repeated every 15 minutes as needed, is highly effective, but can depress respiration and urination, can reduce myocardial contractility, as it seems to be, and is a potent venous vasodilatator. Hypertension, yes, we have to talk about this. A large retrospective trial showed that morphine may increase mortality in patients with acute myocardial infarction. But okay, hypertension and bradycardia secondary to morphine can usually be overcome by prompt elevation of the lower extremities. Standard therapy for all patients with unstable angina includes beta blockers, AC inhibitors, and statins. Beta blockers are recommended unless contraindicated, for example, by bradycardia, heart block, hypertension, or asthma, especially for high-risk patients. Beta blockers reduce heart rate, arterial pressure, and contractility, thereby reducing cardiac workload and oxygen demand. AC inhibitors may provide long-term cardioprotection by improving endothelial function, and if an AC inhibitor is not tolerated because of cough or rash, but not angioedema or renal dysfunction, and angiotensin II receptor blocker may be substituted. Statins are also standard therapy regardless of lipid levels and should be continued indefinitely. So reperfusion. Actually, this is a revascularization, but okay, reperfusion. For patients with STEMI, immediate percutaneous coronary intervention or fibrinolytics. For patients with non-STEMI, immediate percutaneous coronary intervention for unstable patients or within maxi 48 hours for stable patients. So for STEMI patients, emergency PCI is the preferred treatment of ST segment elevation, myocardial infarction, when available in a timely fashion, door to balloon inflation time, less than 19 minutes, by an experienced operator. If there is likely to be significant delay in availability of PCI, thrombolysis should be done from STEMI patients meeting criteria. Reperfusion using fibrinolytics is most effective if given in the first few minutes, 2 hours after onset of myocardial infarction. So that is so-called therapeutic window. Normally it's 120 minutes, but now they talk about even 24 minutes. 240 minutes, so 4 hours. But actually the best time is 120 minutes from starting of angina. The earlier fibrinolytic is begun, the better. The goal is to door to needle time of 30 to 60 minutes. Greatest benefits occurs within 3 hours, but the drug may be effective up to 12 hours. So if the ST segment elevation is present, do your fibrinolytics. If you see elevation of this STEMI, do your fibrinolytics. Characteristics and selection of fibrinolytic drugs will be discussed in another lecture. Unstable patients, the unstable non-STEMI patients, that is those with ongoing symptoms, hypertension or sustained arrhythmias, should proceed directly to the cardiac catheterization laboratory to identify coronary lesions requiring PCI or coronary artery bypass grafting (CABG). For uncomplicated non-STEMI patients, immediate reperfusion is not as urgent because a completely occluded infarct-related artery at presentation is uncommon. Such patients typically undergo angiography within the first 24 to 48 hours of hospitalization to identify coronary lesions requiring PCI or CABG. Fibrinolytics are not indicated for any non-STEMI patients. Risk, overweight, potential benefit. Okay, rehabilitation, rehab. Okay, I'm sorry. Let's talk about revascularization. So revascularization is the restoration of blood supply to ischemic myocardium in an effort to limit ongoing damage, reduce ventricle inability, and improve short-term and long-term outcomes in patients with acute coronary syndromes. Myocardial infarction is also. So modus of revascularization is thrombolytics with fibrinolytic drugs. So actually fibrinolytics is a reperfusion, not revascularization. But okay, let's talk about revascularization. Percutaneous coronary intervention, PCI, with or without stent placement, and coronary artery bypass surgery, so CABG. The use, terming, and modality of revascularization depend on which acute coronary syndrome is present, timing of presentation, extent and locations of anatomic lesions, and availability of personnel and facilities. So immediate reperfusion is not as urgent in patients with uncomplicated non-ST segment elevation myocardial infarction, in whom a completely included infarct-related artery at presentation is uncommon, or in patients with unstable angina who respond to medical therapy. Such patients typically undergo angiography within the first 24 to 48 hours of hospitalizations to identify coronary lesions requiring PCI or CABG. A non-interventional approach and the trial of medical management are used for patients in whom angiography demonstrates only a small area of myocardium at risk, lesions morphology not amenable to PCI, anatomically significant disease, anatomically insignificant disease, less than 50% of coronary stenosis, significant left main disease in patients who are candidates for CABG. Further angiography or PCI should be deferred in favor of medical management for patients with high risk of procedure-related morbidity or mortality. By contrast, patients with persistent chest pain, despite maximal medical therapy or complications, for example, markedly elevated cardiac markers, presence of cardiogenic shock, acute mitral regurgitation, ventricular septal defect, unstable arrhythmias, should proceed directly to the cardiac catheterization laboratory to identify coronary lesions requiring PCI or CABG. As in patients with stable angina, CABG has historically been preferred over PCI for patients with left main or left main equivalent disease, although the data supporting this practice are changing. And for those with left ventricle dysfunction or diabetes, CABG must be considered when PCI is unsuccessful. Can it be used, for example, in lesions that are long or near bifurcation points, or causes acute coronary artery dissection? Fibrinolytics are not indicated for unstable angina on STEMI. Risk overweights potential. Emergency PCI is the preferred treatment of ST segment elevation myocardial infarction, so STEMI, when available timely fashion, door to balloon inflation time less than 19 minutes by an experienced operator, indications for urgent PCI. Later in the course of STEMI include hemodynamic instability, malignant arrhythmias requiring transvenous pacing or repeated cardioversion, and age more than 75. If the lesions necessitate CABG, there is about 4 to 20% mortality and 20 to 43 morbidity rate. If there is likely to be significant delay in availability of PCI, thrombolysis should be done for STEMI patients, needs criteria. Reperfusion using fibrinolytics is most effective if given the first few minutes to hours after onset of myocardial infarction. The earlier fibrinolytic is begun, the better. The goal is door-to-needle time of 30 to 60 minutes. Greatest benefit occurs within 3 hours, but the drugs may be effective up to 12 hours. So you see elevation, you do your fibrinolytics, elevation of ST segment. Used with aspirin fibrinolytics, reduce hospital mortality rate by 30 to 50% and improve ventricular function. Pre-hospital use of fibrinolytics by trained paramedics can significantly reduce time to treatment and should be considered in situations in which PCI within 19 minutes is not possible, particularly in patients presenting within 3 hours of symptoms onset. Regardless, most patients who undergo thrombolysis will ultimately require transfer to PCI-capable facility with cath lab for effective angiography and PCI as necessary before discharge. PCI should be considered after fibrinolytics if chest pain or ST segment elevation persists more than 60 minutes after initiations of fibrinolytics, or if pain and ST segment elevation recur, but only if PCI can be initiated less than 90 minutes after onset of recurrence. If PCI is unavailable, fibrinolytics can be repeated. Okay. So now about rehabilitation. So rehabilitation and post-discharge treatment. Functional evaluation, changes in lifestyle is absolutely necessary. Regular exercise, diet modification, weight loss, smoking cessation, etc. Drugs, continuation of antiplatelet drugs, beta blockers, and AC inhibitors, maybe statins. Patients who didn't have coronary angiography during admission have no high-risk features. For example, heart failure, recurrent angina, ventricular tachycardia, or ventricular fibrillation after 24 hours, mechanical complications such as pneumorama, shock, and have an ejection fraction more than 40%, whether or not they received fibrinolytics, usually should have stress testing of some sort before or shortly after discharge. The acute illness and treatment of myocardial infarction should be used to strongly motivate the patient to modify risk factors. Evaluating the patient's physical and emotional status and discussing them with the patient, with the relative of this patient, advising about lifestyle, for example, smoking, diet, work and play habits, exercise, sexual relationships, and aggressively managing risk factors may improve prognosis. On discharge, all patients should be on appropriate antiplatelet drugs, beta blockers, for statins, antianginals, and other drugs based on comorbidities. Okay, about key points. Acute myocardial infarction is a myocardial necrosis resulting from acute obstruction of a coronary artery. Symptoms of acute myocardial infarction include chest pain or discomfort with or without dyspnea, nausea, and diaphoresis. Women and patients with diabetes are more likely to present with atypical symptoms, and 20% of acute myocardial infarction are silent. Diagnosis is by ECG and cardiac markers. Immediate treatment includes oxygen, antianginals, antiplatelet drugs, and anticoagulants. For patients with ST segment elevation, due to immediate angiography with percutaneous coronary elevation, if immediate PCI is not available, give fibrinolytics. So you see ST segment elevation, you do your fibrinolytics. For patients with non-ST segment elevation myocardial infarction who are stable, do angiography within 24 to 48 hours. For those who are unstable, do immediate angiography with PCI. Following recovery, initiate or continue antiplatelet drugs, beta blockers, AC inhibitors, and maybe statins. Okay, this is the end of the second part. Second lecture, and we will continue, of course. Thank you for your attention, but once again, please do not forget to make your donations to our channel, because without your donations, actually we can't exist. This is not joke at all. I am not exaggerating. So how to do this donation is very easy. You can find the donation choices in description of this video in YouTube. Okay, so make your donations, follow and subscribe our channel, and see you in the next lectures. God bless you.